10 मिनट है सर क्या?
10 मिनट है। अभी क्या मतलब क्या कह रहे हैं?
ठीक है। दो बार। दो दो।
जुड़ा हुआ है।
तुम्हारा।
अच्छा अच्छा। ठीक ठीक ठीक।
ना मुझे कैंसर हो गया है तो
गुड इवनिंग सर।
गुड इवनिंग गुड इवनिंग गुड इवनिंग। आ रहे हैं आ रहे हैं आ गए।
मास्टर टीचर डीन 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 इंडियन कॉलेज ऑफ फिजिशियंस।
मास्टर टीचर तो आप है, हम तो नौकर है आपके हैं।
नहीं सर नहीं सर। मास्टर बड़े मास्टर चीफ मास्टर।
आज खाली कटिहारे भरा हुआ है।
बढ़ेगा सर बढ़ेगा। तीनों कोऑर्डिनेटर्स को भी तो जोड़े हैं, मतलब
ठीक है।
दीपेंद्र राय, राय संजय जी, और इधर पीके अग्रवाल।
नहीं, आपका प्रोग्राम बहुत पॉपुलर हो गया मुझे। आज हमको बंद करना पड़ा,
अच्छा,
रजिस्ट्रेशन बंद करना पड़ा। शक नहीं रहे थे।
नहीं ठीक है, अभी इतना जैसे रजिस्ट्रेशन का तो एक टाइम होना चाहिए ना सर।
अब क्लास शुरू हो गया तो बंद कर दिए।
जी सर, जी सर, ठीक है, सबका एक तो टाइम तो होना ही चाहिए ना सर। जी सर।
फिर खुलेगा टाइम देख के।
गुड इवनिंग डॉक्टर संजय। यस,
प्रणाम सर।
खुश
वेलकम
रहिए,
वेलकम।
खुश रहिए, खुश रहिए, आइए।
ये प्रणाम सर।
नेक्स्ट क्लास में डॉक्टर संजय जी,
जी
हम
सर।
हम रहेंगे इसमें, नेक्स्ट वेडनेसडे को डॉक्टर दीपक तलवार सर का है,
जी सर।
और तो रहेंगे उदयपुर में, तो अगर हमको दिक्कत होगी जुड़ने में,
जी सर।
हाँ आप टेक ओवर कर लीजिएगा उसको।
हाँ ठीक सर, ठीक सर।
और आजमा पर है उनका।
जी सर, जी सर।
कल से तो हम लोग अभी तक वेन्यू मेनू पर ही लगे हुए हैं, माता पचे माता पची पे।
Good evening,
वेलकम
sir.
सर, वेलकम वेलकम। चलिए,
How are you?
फाइन सर।
कैसे हो सिंह सर? कैसे हो प्रदीप सर?
गुड इवनिंग सर।
Good evening,
अगम
everybody.
सर, गुड इवनिंग।
Good evening. Good evening. So I'll just check whether I'm able to share my slide. सर आपको मुझे स्लाइड शेयर का परमिशन देना पड़ेगा।
है
स्लाइड शेयर का परमिशन
व्हाट्सएप
है
पर
ना?
तो होगा। नहीं, मेरे व्हाट्सएप पर तो होगा। हाँ हाँ।
हाँ दिख रहा है ना स्लाइड सर?
जी
दिख रहा है
हाँ
सर,
हाँ।
Oh,
दिख रहा
perfect.
है।
Perfect. 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 I'm all set.
सर ये प्रोग्राम आपका एकदम चल रहा है दनादन, है हिट
आपने सर कुछ हाथ में लिया तो मुझे तो डाउट ही नहीं है कुछ।
हिट कर गया।
नहीं, बहुत
प्रोग्राम को
बहुत
कोई
बहुत
ऑप्शन ही नहीं था,
बहुत
जब
बहुत
आप
अच्छा
हो सिंह
प्रोग्राम है
साहब
सर।
हो सब जुड़ जाओ तो कोई मिराकल स्टिल हैपन, मैं तो ऑलवेज बोलता हूँ।
बहुत अच्छा। अब लड़के लोगों को भी बहुत फायदा होगा सर।
आई नो।
उनको ज्योतिर्मय
बहुत
पवार साहब को जोड़िए ना।
बहुत जरूरी था।
जी जी जी, एब्सोल्युटली।
अच्छा,
चलता है क्यों? कितना चलता है? नहीं चलता है ना।
हाँ, नहीं मिला। अच्छा, तुरंत दे रहे हैं।
ज्योति को बोल दिए।
जस्ट ज्वाइन कर रहे हैं, ज्वाइन कर रहे हैं।
अरे ना।
मिला? हाँ सर, वेलकम सर.
Also
Honorable
joined them here, sir.
President Dr. Jyotirmay Paul. Yes.
Good
Welcome.
evening, sir. Good evening, sir.
Good evening.
Evening.
Good evening, Dr. Agam. Good evening.
Good evening,
Good evening,
President
sir.
sir.
President and secretary both are here. Huh?
डीन सर का हुक्म है तो फिर सवाल ही नहीं ना. डीन सर ने हुक्म किया तो हेलो. हाँ.
Sir, time is Dr. Kamlesh Tiwari, sir, please.
Thank you, Dr. DP. Respected President, my master teacher, Dr. DP Singh, and Secretary, Dr. Agam Vora. I have started this class in a view that in our country, most of the medical colleges have no teachers. That was the idea behind my mind, and I have started this course for each and every subject nearly, and I would like to continue till my tenure. Now I will ask my president, Dr. Jyotirmay, to say something about this program.
Thank you, sir. I am very happy that under able leadership of Professor Kamlesh Tiwari, Indian College of Physicians is taking such a short certificate course on almost in every subject. And today the subject is because India, the vast segment of people is suffering from respiratory problem, particularly COPD, where the smoking is rampant. So management of COPD. So management of COPD and proper guideline is the bread and butter of the physician practicing in India. Today, Dr. Agam Vora, our Secretary General and pulmonologist, is the speaker, and needs no introduction. Very well known pulmonologist across India. I am sure the students and practitioners and our members will be much benefited with his deliberation. Thank you. Over to Dr. Tiwari.
Thank you, sir. Thank you. Now, master teacher, Dr. DP Singh, few words.
Sir, thank you very much, sir. It's a warm welcome on this evening. And welcome to this short certificate course in pulmonary medicine. And I'm honored to have in this class our Honorable President of API, Dr. Jyotirmay Paul, our Dean, Dr. Professor Kamlesh Tiwari, and other friends like Dr. Sanjay Kumar, Joint Secretary and Chairman of API Bihar, Dr. P.K. Agrawal, and all friends. And I'm honored to introduce our first speaker of the first class of respiratory medicine, none other than Dr. Agam Vora, a renowned pulmonologist with vast experience and very famous pulmonologist of India, and vast experience on this in managing respiratory disease. Dr. Vora will be speaking on COPD, diagnosis treatment based on the latest gold guideline, and what physicians must know. And COPD, as you know, is a major public health concern afflicting millions of people across the world. It's a progressive disease characterized by airflow limitation, and its management requires comprehensive approach. And Dr. Agam will teach about that, how to have this comprehensive approach. And gold guidelines provide a framework for diagnosis, assessment, and management of COPD. And Dr. Vora will take us through the journey of this latest recommendation, highlighting the importance of early diagnosis, this lifestyle modification, pharmacological intervention, and how to rehabilitate these all patients. Please join me in welcoming Dr. Agam Vora, and let us benefit from his expertise and experience in managing COPD. Over to our friend, Dr. Agam Vora.
Good evening, everybody. Thank you, Singh sir, for those nice, lovely words of introduction. And trust me, today's program is extremely special for me. It's special for me for a couple of reasons. Number one, it is designed by none other than Dr. Kamlesh Tiwari. Sir was very close to me. Sir has kept his blessings for a number of years. President Dr. Jyotimay Pal is present here. I'm being introduced by Dr. D.P. Singh. Sir was my mentor, and I've learned my respiratory medicine from him. And there cannot be any better compilation to do a program. This program is certificate course. I happen to be the first speaker. That also adds extra flavor to it. With these words, let me share my slides. And what I wish to do in next 15-20 minutes, half an hour or so, is to talk about current understanding of COPD management and some idea about the latest gold guidelines that we have. We've come a long way. We've come a long way from the disease which was considered a neglect disease. It was neglected by all. It was neglected by patients. It was neglected by relatives. It was neglected by you and me because we did not have any therapeutic options. We treated COPD exactly like asthma because we didn't have any different treatment. Most of these patients felt it is due to their smoking habit, and it is the result of sins they've committed in their life. The family members would look down on this patient, saying that it is because of the smoking that he had all throughout his life and let him suffer was the attitude. We were running short of medicines because we had anticholinergic drug called ipratropium, only one drug, and which also needed to be taken a couple of times a day, 3 to 4 times a day, making it less compliant. Those were the times where patients were not comfortable taking inhalers, and obstructive airway disease primarily was managed only with tablets, and hence patients kept on suffering. I remember days when I was a student, we were told not to put COPD patients on ventilator because if you put them on ventilator, it becomes difficult to wean them off ventilator. They remain dependent on ventilator for days together, and you may not be able to, save a salvageable patient because we had handful of ventilators that time. And from there, we have come to today's understanding of COPD, where our patients are on home nebulization therapy, our patients are on home non-invasive ventilators, our patients are on home oxygen therapy, and yes, we can offer them fairly decent quality life. So for this understanding, I must thank my teacher, Professor Director Dr. K.C. Mohanty, who taught me respiratory medicine. My API mentors, I remember Dr. Siddharth Shah, who introduced me to API, my friend Dr. Shashank Joshi, of course, President Dr. Jyotimay Pal sir, Dean Kamlesh Tiwari sir, DP Singh sir being course director of the entire program, my friend Dr. Mangesh Tivaskar, all of you who chose to be here today. It's a working day. Still, you give me your time because your presence means lots to me. And of course, my family. So when Singh sir told me that Agam, you have to give a talk on COPD, the current understanding, I started looking at my last 100 patients of COPD who came to me in my OPD. And I'm talking about only COPD patients. So out of those 100 COPD patients whom I saw in last couple of months, 34 were stable COPD in the sense they came for the regular follow-up, but majority came to me for acute exacerbation, of which 16 require hospitalization because they had severe COPD, severe acute exacerbation. And by severe acute exacerbation, I mean whenever this patient requires non-invasive ventilator, whenever this patient requires oxygen supplementation, whenever this patient has got altered sensorium or hypotension or hypertension, tachypnea, perspiration, these are the situations where they may need hospitalization. Around 50 had mild to moderate exacerbation and they could be managed well on OPD with change of treatment, with increase in that aerosol therapies, with introduction of antibiotics and maybe systemic steroid. 6 had non-infective exacerbation. I'm sure everybody here is seeing this kind of patient with change of weather and the pollution level. You may see exacerbation which are non-infective, and then comes a huge chunk of patients who are non-compliant to the therapy. They feel fine and then they discontinue treatment, leading to exacerbations. And 44 were actually infective exacerbations. And then when I looked at what are the infections that I'm seeing in my area, and I'm seeing significant viral infections. A lot of viral infection gets secondarily infected with streptococci. In a lot of these patients, in spite of battery of investigation, you may not find a bug and you treat them as gram positive, significant streptococci, but yes, significant gram negative, significant Klebsiella and Pseudomonas as well. I was just looking at what happened in last 3 decades. 3 decades because I started practice somewhere around 25, 26 years ago. And in last 3 decades, I've witnessed there is definitely better understanding about disease. From a completely pessimistic definition, a progressive and irreversible disease, now we have come to a disease which is preventable and treatable. This is a change in understanding. There are better quality spirometers. I remember when I was in physiology class, there was a underwater rotating jar, and you blow into that and jar would rotate with displacing water, and a graph would be plotted on that rotating drum was the spirometer. And today we have a fantastic handheld spirometer. Patients just have to blow once and you get basic values. You've got better definitions. Your patient's compliance is better, though I would prefer far better, but then yes, still it is better. Acceptance to inhaler is better. There are better vaccination, and yes, I'm going to touch upon rehabilitation as there are better and better rehabilitation techniques. Looking at the need, last year, under the guidance of last year, actually, under the guidance of the then President, Dr. Girish Mathur sir, we at API have come out with this COPD compass, and anybody who wants a physical copy of this particular book can write to office, and I would be very happy to send you the link or the physical copy if you need. It was published in 2024 and then it was revised in 2025. The idea was there are very specific challenges that we face in our country, and I'm sure a lot of you here would agree that our patients' expectations are different, our weathers are different, our tolerance are different, our treatment compliance are different, and we need to address certain issues which are very specific to our country, and that is maybe non-smoking COPD or post-tuberculosis COPD. And looking at those needs, we designed this particular document, and it is in a very simple question answer format. So whatever questions come to your mind are answered in this, and I'm very happy again to share with you that the Jagdeep Dhankarji, the Vice President of India, released this particular booklet at the Epicon 2024, and we have just revised this particular document. That is 2025 updates are also incorporated. It's available for free download. It's available for free physical copy. Do write to us. This particular document is divided into 4 parts. The first part talks about the management, understanding, and comorbidities of COPD. The second part talks about the pharmacotherapy and the correct inhalation techniques. Then there is a portion which talks about non-pharmacological therapy. And then comes the management of acute exacerbation. So these are the 4 components of this particular booklet. With that, let me come to the problem that we have not only in our country, but look at the problem that we have globally. It is the 3rd leading cause of death globally. 400 million. Imagine 400 million are estimated to have COPD, with 3.3 million deaths globally. Not only that, not only death, it is associated with very high level of comorbidities like heart failure, depression, disability, and even the cerebrovascular accident. And somehow, in spite of being such huge problem, COPD has received relatively little attention compared to other causes of global morbidity and mortality. It's not a problem of only our country. Look at the world map and you will realize everywhere, across the globe, there is significant prevalence of disease that we are talking about. And India cases were somewhere around 50 million in 2016, and second most common cause of death among non-communicable disease. And a gender-wise systemic review reveals that COPD rates in male could range from 2 to 22% and from 1.2 to 19% in male and female. So this is what is the issue. And somehow in our country, we are seeing COPD coming up at least a decade earlier. When I was a student, again, I was told 50 plus COPD diagnosis must be made after 50 years. And now we realize 30 years, at least 20 years earlier is what we are seeing COPD in our country. And if I have to talk about over 3 million deaths per year globally, that means 5 deaths per hour globally. Maybe the time that is allotted to us today for this meeting is 5 deaths. More than 90% of deaths occur in low and middle income countries, which mean 4 in our part of the world. And maybe 10 people would die by the time our meeting ends. That is the problem of COPD. And we never realized. COPD kills almost equal number of patients or people as you have death happening due to tuberculosis. So that's huge is the problem. And as we understand COPD today, that it is defined as it's a heterogeneous lung condition characterized by chronic respiratory symptoms. So whenever you have a symptom, try of breathlessness, cough, and sputum production, which is due to abnormalities of the airways. That means your airway abnormality or your alveolar abnormality. That means bronchitis, bronchiolitis, or emphysema, which causes persistent, often progressive airflow obstruction. So you have to look at shortness of breath, cough, and sputum production. And whenever you have the right risk factors, which is like pollution, that means if you're breathing polluted air. But still, if you have exposure to indoor or outdoor pollution, if the occupation puts you at a higher risk, if you are consuming tobacco in any form, be it hookah, bidi, cigarette, there are so many forms of tobacco inhalation in our country, or if you have those host factors, you could be dealing with a case of COPD. And whenever you have this symptoms, this risk factors, do ask for spirometry. You need spirometry for confirmation of diagnosis. In bold very clearly says that COPD diagnosis is only by spirometry. You can clinically only suspect, but diagnosis is on spirometry. Not like asthma. Asthma is complete clinical diagnosis. You don't need spirometry for making up diagnosis to establish diagnosis. You may do it in situations where you have a differentials in mind or you want to judge response to treatment, etc. But here in COPD, spirometry is must for establishing a diagnosis. Look at this scenario. We are talking about India. 2.5 billion people rely on biomass. They are relying on what? Charcoal, fuel wood, agricultural waste, animal dung to meet their energy needs for cooking. And this is not only in our country. Look at US. US EPA estimates that firewood smoke contributes over 420,000 tons of fine particulates in US. And the data says US consumes 1/10 of fuel wood consumption by India. That means हम जितना यूज करते हैं उसका only 1/10 they are using, and if that is 420,000 tons of particulate matter, you can imagine what must be happening in rural India, what must be happening in urban India. An Indian chula, there is a lot of people, more than 100 million household, thanks to Modi ji, where he's made special subsidies on gas, but still more than 100 million household use chula and dung cakes, fuel wood, or even trash as cooking fuel, not only once, maybe 2, 3, 4, 5 times a day. And somehow, even in 5-star hotels, off late you see there is a fashion of making rotis or those naan on this kind of chula, on this kind of charcoal burnt roti is a fashion. And you can imagine it leads to so much of increase in particulate matter. Forget those 5-star hotels. Look at this house. This house, I'm sure, would have very poor ventilation. This house may have a small child who's just born living in the house 24/7. This house may have a senior citizen, 60, 70 years old, may be bedridden and is exposed to this particulate matter continuously. This house is this lady who cooks 3, 4, 5 times on this chula and is exposed to this kind of particulate matter. No wonder she's going to be at a higher risk of COPD development. And yes, smoking, not only cigarette, but bidi, not only in men, but women. And there comes another big problem in indoor pollutants, that is mosquito coils. This is puja sticks, those incense sticks. And then comes this festival, this Ganpati festival, and there's so many festivals. And then you have so many puja artis going on. Entire family is exposed to those particulate matters, putting them at a risk of development of COPD. And with that comes breathlessness, which may be at rest or on exertion, cough with or without sputum production, chest tightness, and wheezing. That's a chronic component which goes on for number of days, number of weeks, number of months, number of years before they present to you. And they feel that is due to advanced age. Most of these patients have got multiple illnesses. They may have blood pressure, they may have diabetes, they may have obesity, they may have arthritis, and they may feel it is because of aging without realizing that there is underlying COPD which is progressing at a much faster pace. The acute exacerbation is sudden worsening of COPD status, which generally lasts for about 7 to 14 days. So breathlessness, cough, wheezing, chest tightness, sputum production, fatigue, and it has got huge impact on social well-being. It leads to activity limitation, it leads to anxiety and depression, it leads to apprehension about future events, lack of confidence about activities, risk of increasing social isolation, and yes, it leads to loss of independence, and it needs to be addressed. Gold has recently proposed this ABE assessment tool. So what you do, Gold tells you whenever you have this high risk population, anybody who's exposed to indoor or outdoor pollution, anybody who's exposed to indoor outdoor pollution, anybody who's got smoking habits, anybody who's got that kind of occupation, anybody who's got family history, anybody who's got genetic predisposition to development of COPD, and anybody who's got cough, shortness of breath, sputum production, subject them to spirometry. The first thing is written is spirometry for confirmed diagnosis. You cannot make diagnosis clinically. You look at the airflow obstruction after that. So what will you see in spirometry? In spirometry, you have to look at FeV1 by FVC, the hallmark for obstruction. So when you see FeV1 by FVC, you give them bronchodilator, and if it improves by 200 ml or more than 12% increase in FeV1, it is a reversible airflow obstruction, which is asthma. We are not talking about that. If you have post-bronchodilatory FeV1 by FVC less than 0.7 or FeV1 which is not improving following salbutamol inhalation, we are talking about irreversible obstructive airway disease, which is COPD. After you confirm FeV1 by FVC of 0.7, that means after you confirm obstructive airway, you look at FeV1 value. FeV1 value will tell you the severity of obstruction. So you judge severity of obstruction depending on FeV1 value. If it is 80% around, it is mild. 50 to 80 is moderate or severe. More severe and extremely severe is about less than 30%. Mild, moderate, severe, and very, very severe is the level of obstruction. That is gold 1, 2, 3, and 4 severity. After having done, you remove that. You don't look at that. You look at only two variables. One variable is CAT score or MRC score. Everybody here is aware about the MRC score. Whether you are able to walk at a people of your age at a pace with them, or you are absolutely bedded and moribund, is a scale from 0 to 4. So you have MRC 0 to 1 puts it in the A category. So when you have a low symptom, that means you're getting breathless only on heavy exertion. Or when you have the CAT score, if you have a habit of calculating CAT score, if you put CAT score, if it is less than 10, that means patient is less symptomatic, you put them in A category. If patient is more symptomatic, that means he gets breathlessness on minimal activity, or is breathlessness at rest, or is moribund or bedbound, you put him in B category. Or if you're looking at CAT score, any score of more than 10 puts him in this B category. Now, this is divided with a horizontal line depending on the number of exacerbation patient had in previous year. So anybody who requires hospitalization goes into category E directly. Anybody who is not led to any hospitalization or had mild to moderate exacerbation is kept in A and B. So anybody who had major exacerbation requiring hospitalization straight is put in category E. If this patient had 2 or more severe exacerbations in past 1 year, he's put in category E. If this patient has got less exacerbation, then depending on his symptoms, he's put in A category or B category, and this is how the assessment is done. So you confirm diagnosis, do their PFT, look at FEV1 values, label them as gold 1, 2, 3, 4, mild, moderate, severe, or very severe obstruction. Then look at the number of exacerbation patient had in previous year. If one hospitalization in E, if no hospitalization, he is in A or B, and he, depending on the symptoms, he would be either low symptom A, high symptom B. After having done that, you decide treatment. To treatment, most of the time when patients come to you, they would hardly come to you in group A. Group A patients you would be able to pick up only if you have habit of doing spirometry. So whenever you do the spirometry for those health checkups and etc., whenever you do spirometry for patients who come to you for various other disorders, and that time spirometry is done, and if you pick up them having obstructive airway disease, you put them in group A. But whenever these patients are symptomatic, most of these patients would present to you in group B situation where they're on LABA and LAMA combination therapy. And whenever this patient had severe exacerbation in previous year, whenever is put into category E, that is the time you initiate them with LABA and LAMA therapy, and you give them inhaled corticosteroid depending on the eosinophil counts. And the current gold guideline says that if you have to use combination therapy, it must be used with single inhaler. So rather than giving them multiple inhalers, if you give them single inhaler, not only the compliance, but it is far more effective in treating. With that, let's look at what are the bronchodilators available today. So there are two group of drugs available in bronchodilator category, and one is beta agonist. So we have salbutamol, we have, when you're talking about long-acting beta agonist, we have formoterol, we have salmeterol, and there are three new molecules called indaketrol, vilantrol, and olondetrol. So these are 5 LABAs which are available in our country. And then there is anticholinergic drug, which also acts by mediated by M3 receptor blockage, which leads to bronchodilation. And you have glycopyrrolate, we have tiotropium, and 2 new molecules, that is eclidine and umeclidine. Glycopyrrolate is the most commonly used anticholinergic as of now, but we have umeclidine available today. And then these are the fixed drug combination which are available in our country. So we have vilantrol and umeclidine available, which is once daily. You have formoterol and glycopyrrolate, which is most commonly used twice daily. And we have indicatrol and glycopyrrolate also available as once or twice daily preparation. And this FDCs have benefits of reducing the dose burden, the inhaler burden, and it has got synergistic action with maximum bronchodilation. And it also helps simplify the treatment regimen. Rather than giving them 2 different inhalers with once or twice, patient may forget and may mistake the inhaler. Rather, if you give them this combination, probably it has got advantage of simplifying the treatment regimen. Bronchodilators level A evidence. Combination therapy of LABA and LAMA increases your FEV1 and reduces symptoms compared to monotherapy. So if you give only LABA or only LAMA, you give only tiotropium, or you give only formoterol, response is inferior. But if you combine them, the response is much better. Combination treatment with LABA and LAMA reduces the exacerbation also. So there is symptomatic improvement and reduction in exacerbation, and you've got very high degree of evidence available for both this. Dual combination versus monotherapy, and you've got huge Cochrane review available with more than 1 lakh patients, and it says the combination therapy reduces moderate to severe exacerbation. So when you look at this particular graph, you look at the combination therapy there versus monotherapy, and it tells you all these favors that when you give them, there is far better symptom control and there is significant risk reduction to number of moderate to severe exacerbation. You have initiated patients on treatment, and then patient will come back to you either in 3 clinical situations. 1, patient says he's fine. If he's fine, you continue the same treatment. And otherwise patient says he's not fine. When he's not fine, you have to look at what trail he follows. That means whether he's got more dyspnea or he got more exacerbation. But before you look at this traits, you will look at the adherence, how regularly patient takes the treatment. You will be surprised to know that even after years of usage, patient may not be taking his inhalers completely properly. And there may be comorbidities which you have not assessed. So maybe pulmonary hypertension that you missed, sleep apnea you missed, maybe associated cardiac comorbidities we missed, maybe associated asthma we missed. And if you miss all this, patient may have inadequate improvement. So first, you will look at the compliance of the patient, look at the technique, and look at any associated comorbidities that you missed. After that, you look at which trail. That means whether he is more dyspneic or he's got more exacerbation. If he's got more dyspnea and if he's on combination therapy, you switch inhaler. So you may have put patient on MDI, try putting him on DPI. If he's on DPI, try putting him on MDI. If he's on MDI, you may give spacer. You may actually escalate the dosages there. And you may actually switch the molecule. That means if patient is on one beta agonist, you may give him the second beta agonist. If patient is on one anticholinergic, try with other anticholinergic, and you may be surprised to know that just by changing the molecule, patient may have far better improvement. If patient keeps on getting more exacerbation, these are the situations where you will look at patient's eosinophil count. So if patient has got associated asthma, if patient gets frequent exacerbation, these are the patients who have got higher eosinophil counts. If they've got higher eosinophil count, probably these are the candidates for triple drug therapy, and you will give them LABA, LAMA, and inhaled corticosteroid, preferably in single inhaler. This is in a nutshell, how will you approach or how will you manage a case of COPD? The first thing is diagnosis, symptoms, risk factor, spirometry. After that, do initial assessment, judge the severity of obstruction. You will label him as gold 1, 2, 3, 4. And then looking at CAT scores, exacerbation history, and associated comorbidities, you will put them in the appropriate matrix. He would be either into A, B, or E. Then you initiate treatment. But by the time you initiate treatment, don't forget to assess comorbidities. Don't forget to advise smoking cessation. Don't forget to teach him about vaccination and give him the risk management plan. Don't forget to tell him to avoid allergens and do emphasis on physiotherapy plan. After doing all this, you put him on the right initial pharmacotherapy. You review him maybe after 6 to 8 weeks first time, and then maybe once in 3 months. Look at the compliance, look at the inhalation technique, look at the smoking cessation, look at the overall rehabilitation plan, do spirometry once a year. And if patient is stable, continue same line of treatment. If patient is not stable, if he's breathless or gets number of exacerbation, you adjust therapy. Not only focus on pharmacotherapy, but also look at non-pharmacotherapy disease management. Current COPD understanding tells us that there is a very small position of inhaled corticosteroid in COPD. You will use inhaled corticosteroid in COPD provided this patient has got severe exacerbation which requires hospitalization. He had number of exacerbation in previous years, or he's got associated asthma with high eosinophil counts. But if patient has got repeated pneumonias, if patient eosinophil counts are less than 100, or if patient had history of tuberculosis, etc., be cautious in using inhaled corticosteroid. In such situation, by adding inhaled corticosteroid, you may do more harm than good. And if you have situations like this, you may upfront start triple drug therapy. So patient who present for the first time and have severe obstruction and are symptomatic, you may upfront start them on triple drug therapy. Patient who had more exacerbation, patient who require hospitalization, who have eosinophilia, who have associated asthma, who had significant lung function decline, you have spirometries, and if patient is discharged from the hospital after exacerbation, These are the patients for triple drug. COPD Compass, the book you're going to soon have, or which is going to be available at our website. This is our recommendation. In our book, we have mentioned that patient who's got risk factors, symptoms, and the clinical situation, you ask for spirometry, confirm the diagnosis. If he's low symptom, you put him on LAMA. If he's high symptom, you put him on combination therapy. If there is exacerbation or if patient is inadequately controlled on that, you put them on triple drug therapy. And yes, there is role of mucolytics, there is role of xanthines. Somehow in India, we have soft corner for using phosphodiesterase group of drugs. That means your aminophyllins and deriphyllins and theophylline and acetophyllins, etc. And then there is a role of mucolytics as well. There is subset of patients who may respond to drug like roflumilast. There is a growing recommendation of using azithromycin for its immunomodulatory properties. And yes, soon we are going to see biologics. There is a new biologic which is on the way, and that is called dupilumab, which is soon, I think in next quarter, it is going to be available. So future is going to be very interesting with these biologics coming in the management of COPD. As of now, in the respiratory field, we have only 3 biologics available for asthma. We had omalizumab, mepolizumab, and benralizumab are the 3 biologics. And now dupilumab, which is going to be the 4th biologic, which is going to be available for COPD with type 2 inflammation. I would end my presentation today that there is mounting evidence from clinical trials and meta-analysis that dual bronchodilator therapy, that means formoterol and glycopyrronium or indicator, one beta agonist and one anticholinergic drug, is highest ranking therapy for patients irrespective of the history of exacerbation. Inhaled corticosteroid can be useful and add-on in specific set of patients. There is advantage of using single inhaler with multiple drugs in it rather than multiple inhalers with single drugs in each. I thank you all for your patient hearing. If there are any questions or any difference of opinion, I would love to address that. Thank you, Dean sir.
Heartiest thanks, Dr. Agam. Huge congratulations for the excellent deliberation. And I hope our PGs and all those who are listening must be benefited. But there is only one question in the chat box, that is from where we can buy COPD Compass. And
you don't need to buy it. You have Dr. Kamlesh Tiwari sir here, you have Dr. DP Singh sir here. You just have to write a mail to him and it will be given to you as a complimentary copy.
Dr. Agam, just there is sometimes this difficulty in diagnosing overlap syndrome, that whether it is a case of asthma, whether it's a case of COPD, just please throw some light.
Yes,
for the benefit.
That's a fantastic question. Couple of years ago, Gold proposed a term called asthma COPD overlap. It was coined as asthma COPD overlap syndrome, ACOS. But then we realized it is not a syndrome. It's a different phenotype, and hence it was soon changed from syndrome to asthma COPD overlap. But in current guidelines, it is removed. So now we don't have any term called asthma COPD overlap, but we believe there is a patient who's got COPD with asthmatic phenotype or with some reversibility, and there could be asthma with remodeled airway and no reversibility. So I think I would now recommend to look at asthma with reversibility or asthma or COPD. You may say COPD with reversibility of asthma irreversibility, something like that. And hence, it is when you label them like this, it tells you the predominant treatment would be of asthma. And here it tells you that predominant treatment would be from COPD angle. So currently, there is no term as asthma COPD or asthma COPD overlap or asthma COPD overlap syndrome. We now believe that it may be COPD with some reversibility and asthma with inadequate reversibility. Thank you.
There is another question from the chat box. What about the delivery system used in COPD? When to use MDI or when to use special? Because, there are different subset of patients in the Indian scenario. They are not educated, uneducated people coming from the rural areas. They do not understand that the synchronization of this inhaler and like that. The question, over to you.
So Zakir Bhai, thank you very much for that question about delivery system. Delivery system plays major role in disease management. And if your patient cannot take, you may have chosen the best of the device, but if your patient cannot take the inhaler properly, it's going to be of no use. And hence, it is very important that we spend enough time with patients and help them teach all steps of taking the right inhalation. And now AI comes to your help. You have so many YouTube videos about how to take the right inhaler. In fact, we have also incorporated one QR code in our book where patients can go into that code. In fact, there is one more book which is released by API and it's called Home Nebulization Therapy. This is released this year.
Yes.
You will also, if you want that copy also, you will be able to receive. All you have to do is write to Singh sir, and Singh sir would be very happy to share it with you. So there also we have kept QR code. All you have to do is scan the QR code. It will take you to the video about the right technique of using nebulizer, right ways of cleaning nebulizer. So similarly, there are a lot of such links available. There are a lot of patient educative material available about taking the right technique of taking the inhaler. Having said that, when I was a student, I was of the opinion that MDI with spacer is all that your COPD patient requires. And if they cannot do well, you have to give them nebulizer. But now, with the newer devices, there are enough studies done nationally and internationally. Even 30 or 50 ml of inspiratory flow, which is very minimal flow, is adequate to dispel this particular drug from DPIs. And hence, a lot of these drugs are available only in particular combination. So if you're looking at a particular combination, it may be available only in DPI form and it may be available only in MDI form. If you make the right choice of this particular combination drugs, the delivery system in which it is available will definitely get delivered in the lungs of your COPD patients. If your COPD patient has got even bad disease, and if you feel they are not able to understand it well, you may have to use nebulizers. Thank you.
Thank you, Dr. Agam. You know that if doctors and physicians have got no time to teach the patient that how to take this delivery system, spacer or this spacer or rotahilar, the doctor should not prescribe it unless you have got the time to teach the patients. That is one. The next question is there any difference in approach of a patient of chronic bronchitis with evidence of pulmonary hypertension and emphysema or without it? Just
excellent. So Dr. P.K. Agrawal, thank you very much, sir, for your question. Yeah. Pulmonary hypertension. So by and large, if you look at pulmonary hypertension management, pulmonary hypertension, as our understanding goes today, is divided into 5 different classes. So your first class is pulmonary arterial hypertension, which is seen in your young patients or maybe systemic sclerosis patients or HIV, etc. Then comes second category is any pulmonary hypertension which is secondary to heart disease. So you have a valvular disease and septal defects leading to pulmonary hypertension. Third is respiratory. So whenever you have interstitial lung disease or obstructive airway disease or sleep apnea, etc., is grouped into third. Fourth is major chunk, and that is pulmonary embolism, thromboembolic disorder. And fifth is all rarer disorder, your schistosomiasis, and etc., etc. So when you're talking about pulmonary hypertension associated with chronic bronchitis or COPD, it comes into third group of pulmonary hypertension. These are generally secondary pulmonary hypertension. This pulmonary hypertension are generally mild. Mild pulmonary hypertension in a case of COPD does not require any specific treatment. But whenever there is mild pulmonary hypertension, it means that the patient is hypoxic. The mechanism of development of that pulmonary hypertension is hypoxia related. And there you may have to add oxygen therapy to your patient. So if you pick up pulmonary hypertension, try to find out if it's spirometry. I'm sure his FVC would be less than 1.2. If you get chance to make patient walk and check the saturation, you will realize that there is fall in saturation. And if you do their blood gases, there may be hypoxia. So this patient would require long-term oxygen therapy. Thanks.
Thank you, Dr. Agam. And you know that the prognosis of a patient of COPD depends upon this vaccination, this oxygen therapy. And that's very important. And cessation of smoking, that's again very important. So one question is, when and how long we should use LTOT, long-term oxygen therapy in COPD patient?
That's SAFE. Wow, Saifi ji, thank you very much for that question. Long-term oxygen therapy. So the label itself says it's a long-term. So by and large, whenever your patient requires oxygen therapy, there are two situations. One situation is patient's got acute exacerbation, he's admitted, getting discharged, is not fully recovered, and you would use oxygen at home for that duration. But when you call it as long-term oxygen therapy, it is mainly used for patients who's got advanced disease. By advanced disease, we mean most of the COPD, if I take by most, none of the COPDs are going to have reversible component. COPD is a progressive disease. COPD is an irreversible disease. So once you reach the stage where you require oxygen, generally this oxygen requirement does not go away. And hence, this patient would require oxygen for rest of their lives. When patients ask me, when will you stop my oxygen? I tell them, okay, when your oxygen, I will stop your oxygen when your probably glass requirement goes away, when your antihypertensive drug requirement goes away, when your anti-diabetic drug requirement goes away, that is the time. By and large, these are chronic illnesses and the requirements are irreversible. They would continue to need it. Thank you.
And that is one drug that can prolong life, oxygen therapy.
Yes.
Yes. Another question is, in a patient with severe COPD and chronic hypercapnia, why might excessive oxygen supplementation worsen respiratory failure? Yeah.
Arre wow, Dr. Ghulam Arshad. Arshad bhai, that's a fantastic point. So in our over-enthusiastic attempt to correct hypoxia, many a times we supplement them with higher oxygen. If you, if I have to tell you, the respiratory center is stimulated by two stimuli. One is hypoxic stimuli and one is hypercarbic stimuli. So whenever you give higher oxygen, probably their hypoxic stimuli goes away and it leads to more CO2 retentions, and hence patient may be pushed into type 2 respiratory failure. We must be very rational in giving prescription for oxygen therapy. So in your ILD patients, in your pneumonia patients, you may give them higher oxygen. You may give them 4 liters, 5 liters. You may give them even venturi mask oxygen by 40, 50 and 60% if I have to. But when it comes to COPD, we may have to use very low oxygen, that is 1 liter or 2 liters per minute, not to cross those 2 liters per minute. Thank you. That's a nice question.
Dr. Agam, a patient of this acute exacerbation of COPD, how long this systemic steroids should be used? Systemic steroids.
I have a habit of using systemic steroids for a shorter duration. So what I do is when I'm discharging this patient or whenever this patient is given systemic steroid for the exacerbation on OPD basis, I classically use it for about 7 to 10 days. But I supplement them with inhaled steroids for sure. So by the time those exacerbations settle, inhaled steroid takes over. So you don't really need to give it for a longer duration. And if you have not exposed your patients to multiple steroids, you don't need to taper steroid. You can actually stop that particular steroid. I have a habit of using 4 milligrams or 8 milligrams of methylprednisolone. And I would use it twice daily for about 5 to 7 days to 10 days, and you abruptly stop it. You don't really need to make it half and one and then stop it.
And even we can use the 40 milligram of prednisolone for 5 days and stop it.
Yes.
That is also one of the recommendation. Dr. Taneja has one question. What should be the ideal guideline for domiciliary oxygen? Nasal or via mask versus mask?
When Dr. Taneja is asking me question, it feels like I'm giving my viva. Sir is testing me. He's like kind of asking me these questions too. So thank you, Taneja sir, for joining. I'm so happy that you're there. Your presence encourages me. Ideal guideline for using domiciliary oxygen. So your clinical evaluation. So one would be patient is hypoxic at rest. When he's come to you, he is hypoxic. By hypoxia, I mean you just check the saturation and the saturation is less than 90, probably is hypoxic. If you feel your patient's saturation is normal, you make him walk. And he walks for 6 minutes, forget 6 minutes, even in your cabin, if he makes 1 or 2 rounds, you check the saturation. If there is drop of about 4 units, this is hypoxia. Patient may not have resting hypoxia, but this patient may also have hypoxia happening at night. So there may be associated sleep apnea, and you may have to prescribe oxygen at night during sleep. So this may be hypoxia at rest. This may be hypoxia on minimal activity. This may be hypoxia on exertion or this may be hypoxia at night. So you have to look at situations like this and give them appropriate prescription of oxygen for that particular situation. Thank you.
Thank you, Dr. Agam. There is again first steam inhalation followed by nebulization, then O2. This gives better delivery of O2 to small bronchioles. That is Dr. Taneja's suggestion, is it?
Interesting. That's these are practical pearls or the wisdom that you gain over years of your experience, and by and large, steam inhalation does not dilate the airways. So if you have a
Yeah.
clinical situation where patient is hypersecretor, or if you have a phenotype where there is excessive mucus production, and if this patient is unable to bring it out, you may do it. But sir, I have slight disagreement on this. Many times what happens, these patients are mouth breathers. They're breathing like this. There is a lot of dryness of airways. Patient may be dehydrated. And then there is a lot of thickening of this mucus, and this mucus is stuck to the walls. This steam may not always help if you have not adequately hydrated your patient. Even mucolytics does not work well if patient cough reflex is poor. So you have to look at multiple things. But I understand the philosophy behind. By steam, you help liquefy those secretions. By nebulization, there is further bronchodilation, and oxygen would ease out the work of breathing, would make it easier for patients to get out secretions. That formula could work in some patients. Thank you.
Dr. Agam, as you know that COPD is a lifelong disease, progressive disease, even the inhalation, different modules, that is not
Yes.
going to cure the patients. What about the
Correct.
rehabilitation? What we physicians should do to have the rehabilitation for these patients who are not being cured? Yeah.
So rehabilitation forms very important or the integral part of disease management. There could be various ways of doing rehabilitation. So for rehabilitation, there are various components. Sorry, I could not go into the details in my presentation, but there are certain prerequisites. First is what you do is you thoroughly evaluate the patient and put him on optimal pharmacotherapy. You don't subject them to rehabilitation unless you've given him the right bronchodilator, unless you've corrected his sugars, unless you've corrected his hemoglobin, unless you've given him adequate proteins. So this is called pre-evaluation. You evaluate him thoroughly, put him on the optimal therapy, do an initial assessment, look at his PFT, look at his 6-minute walk test, look at what kind of deficit he has, and then give him the prescription for rehabilitation. Rehabilitation would include chest physiotherapy, endurance exercises. It will also include nutrition. It also include counseling. It also includes the psychotherapy or the emotional support that patient may need. After successfully running him into that particular program, which may be clinic based, which may be phone based, and you've got fantastic now, WhatsApp programs available where you can enroll into those programs, and they do online teaching of these exercises. You enroll into any of these programs. At the end of 6 weeks or 12 weeks, you reassess this patient. You do the spirometry again, you do the 6-minute walk test again, and you will be able to appreciate improvement there. Not only there, your pulmonary rehabilitation also includes vaccination. We have, API has prepared a guideline for you about adult immunization. If you get chance, do go on the API website and download that document as well. And if you want, write it to Dr. DP Singh, the same formula, and Dr. DP Singh would be very happy to supply that copy to you. Of course, complimentary. And we have written in that vaccination guideline that every COPD patient, every COPD patient must receive pneumococcal vaccination and influenza vaccination bare minimum. There is growing evidence that even Shingrix vaccination may be required.
I think it is an excellent class. Whether students will feel happy or not, but I am feeling very happy because I am feeling like a student, third student, learning many things. Thank you very much for your class, and we will hope that if DP Singh will like, we will call you again in this class.
Yes, of course, I will call him again. So
thank you so much.
So please give big hands to him, whoever is audible. Yes, that is the big hands to Dr. Agam. Fantastic, excellent, super.
Thank you. Thank you.
Well begun is half done. My job is half done.
I must thank you for the opportunity that you gave me, and comments coming from Tiwari sir and comments coming from Singh sir add value to it. I'm so happy. Thank you.
Thank you. Thank you, sir. Thank
Thank
you.
you.
Thank you, Tiwari sir. And thank
Thank
you,
you.
Anand. Thank you, Agam. Yeah. Thank you, all the students and all the doctors present in this year.
I am also a student.
Sir, we are a student of medicine and perpetual student of medicine. That is the motto. If you want to be updated, we want updated. Yes, sir. We should be perpetual students, sir. Sure, sir. So thank you, sir. Next is the class will be on next Wednesday by Dr. Deepak Talwariya.
For me, it is every day.
ठीक है सर. Thank you, sir. Thank you,
Yeah.
Anand. Thank you, Close.